All right. Good afternoon, everybody. On behalf of the Bern University of Applied Sciences, I would like to welcome you here in Bern. It's sunny, a bit cloudy and windy, but could be a good day for skiing too. But we are here now inside at the building at the Schwarztorstraße with our guest lecture, who I will introduce briefly in a few minutes. First, let me thank a couple of people. We have Stefan Weffler, the technician and head of Skills Center, who helps us to broadcast the whole event on live stream. And that means that we have many more people following us today. We have people from Germany, Austria, from Brazil, and of course from Switzerland. From various institutions. We have people from hospitals, private practices, and of course from the universities. So good afternoon and good lunch to the people in Brazil. And I would like also, because I know some people have to leave earlier, I would like to introduce also the next guest lecture, which will be on a Tuesday, the 14th of May. And we will talk about injuries and running injuries and consequences in terms of disability and what we could do for prevent running injuries. So we're looking forward also to the next guest lecture. Our guest lecture today, he has traveled a bit during his career. He has been trained as a doctor in Colombia and then moved to the Netherlands and did his, I think you did a ton of titles. I've just mentioned a couple of one. One is the Doctor of Clinical Epidemiology, and then you did also a PhD in cardiovascular disease prevention and public health, the topic of today. And then you moved to the UK, and I think you have been engaged also in the industry, in Unilever. So Oscar Franco is the speaker of today. He has been then further on in the Netherlands. He moved back to the Netherlands and as a professor of preventive medicine at the Department of Epidemiology in Rotterdam, and is since last summer the new director of the ISPM, the Institute of Social and Preventive Medicine in Bern. So we are honored and pleased to have you here, Oscar, and the floor is yours. Thank you for accepting the invitation.
Thank you, Mauricio, and thank you everyone for being here. The honor is mine to be here, and it's great to be able to talk about something that I've always been fascinated with, which is the heart. Not because of the heart, but because of the feelings. And to start to talk about the heart, we'll start talking a little bit about art. And everybody is familiar with this painting. It's Mona Lisa, Madonna Lisa, or La Gioconda, painted by Leonardo da Vinci between 1502 and 1506. And this year, I think, is the 500 years of the death of Leonardo da Vinci. It's a special year. And I wonder always, and I always ask my colleagues, have you ever thought of how the Mona Lisa would look like if Leonardo da Vinci or La Gioconda will be exposed to the 21st century? And I wonder, maybe the Mona Lisa would look like this. Or maybe would be like this, or like this. And every time I tell this story, people spoil my story and say, if Leonardo da Vinci would have been exposed to the 21st century, he wouldn't have painted this woman. He would have painted maybe a celebrity at the time and would look like this. Or will paint someone of you here in the audience, or someone watching this presentation, and the Mona Lisa will look like this, no, or like that, right? Either way, the point that we're trying to make is the circumstances can change dramatically in the times of the Leonardo da Vinci Mona Lisa. And what we have seen in one of the greatest successes of humankind in history ever is if we look at record life expectancies, since reasonable records exist 1850, when we look at record life expectancy, we see that in the last 150 years, humankind has experienced an increase of 45 years of life expectancy. People translate this that for every week you live, you gain a weekend. And I translated that for the hour that you're going to listen to me, you will gain 20 minutes. You owe me 20 minutes. All you have to do is stay alive. That's all. And if you fall asleep, don't worry, because sleep is also good for you, so you might actually gain more time. This is the circumstances that we're seeing. Populations have changed, life expectancy has improved, and we expect that in the future, the Mona Lisa of the future could live maybe on average 100 years or more. What has this meant for us, and why am I bringing this up? What has meant is by the beginning of 1900, the top causes of mortality in a country like the US were tuberculosis, pneumonia, and diarrhea. And we see that with the changes that have occurred in environment, in lifestyle, in habits, with the changes and improvements in maternal mortality, child mortality, has meant that people live for longer, and the number one cause of mortality and morbidity became coronary heart disease, stroke, and cancer. And this is basically what we see, this transition in 20 years between 1990 and the year 2010 in the world. Ischemic heart disease became the number one cause of mortality and morbidity. It's not just for the people living in the US or the typical executive running around with a briefcase. It actually kills more women than kills men, and it actually kills more people in low and middle income countries than it kills people in countries like Switzerland. It took a while, nevertheless, until 2012, when the United Nations finally got together and came up with a resolution to improve the way that cardiovascular disease, and not just cardiovascular disease, but non-communicable disorders, could be prevented. And this can be summarized on something that was called the 25-25 target. Basically, what it refers to is reducing by 25% by the year 2025 the mortality due to major non-communicable disorders that share the majority of the common risk factors: coronary heart disease, stroke, cancer, COPD, diabetes, and chronic kidney disease. How can we prevent this, and how can we achieve it by the year 2025? Let's start first looking at what is happening already for the last decades. And we see that cardiovascular mortality has been decreasing progressively. We have statins coming around here, then statins were implemented, new surgery, new stents, etc., that meant that people can survive once they get a cardiovascular event. In the past, if you get a myocardial infarction or you get a cardiovascular event, you were almost dead immediately. Nowadays, improvements in medication and treatment have meant that mortality has decreased. However, this hasn't been easy. If you look at the amount of procedures, catheterizations, and operations that have taken place, have been more than quadrupled in the last decades. And you already can anticipate that if you start operating almost everyone or almost every single event that comes to your operation room, you're going to have a huge increase in cost, right? And we could expect that the cost of treatment of cardiovascular disease could triple or quadruple with time. Do we actually have an increase in resources available to expend in treatment? Is this reasonable? So far, the emphasis on prevention and treatment of cardiovascular disease has been focused on operating more and operating better with every time more expensive treatment. Can we continue living like this? If we think about cardiovascular mortality and cardiovascular disease, we are talking about a balance, which is treatments and population risk factors. And until now, the majority of the emphasis has been on treatment. How about population risk factors? Can we do something there? Could we actually improve population risk factors to avoid that people get treated? And it's good that we continue advancing technology. By no means I mean to say that we should halt technology and development in treatment. That should continue. But we should be able to keep people as much and as long as possible from actually experiencing treatment. And I think that's the only way that we're actually going to bring this balance back. So let's talk about population risk factors. Population risk factors are not necessarily an old concept. We know cardiovascular disease for centuries, for millennia. There is even a study in the Lancet where they took a number of mummies from all over the world, Europe, Egypt, and other places. They ran them through a CT scan to see whether they had atherosclerosis. they found that 1 in 3 had atherosclerosis. And the older they were, the more atherosclerosis they had. So cardiovascular disease and the atherosclerotic process, the formation of plaques in your vessels, is not something new. But for many years, we didn't know what were the risk factors. It took a lot of time, and it took a large population study, such as the Framingham Heart Study, to be able to shed some light into what are the risk factors for cardiovascular disease. While we're seeing a lot of people dying during the 20th century out of cardiovascular disease by this transition that I mentioned at the beginning, going from infectious diseases to heart disease, we didn't know why they were dying from coronary heart disease. And Framingham Heart Study was a study that started in 1942, precisely to understand why were these people dying from cardiovascular disease. Small town close to Boston, 5,000 people, and thanks to them, we now know so far some of the major risk factors of cardiovascular disease. And they're pointed and summarized here. But I would like to, in the coming minutes of the presentation of this seminar that I'm sharing with you, to go through some specific aspects regarding hypertension, smoking, obesity, physical activity, and alcohol. The issues with hypertension, which is now the number one cause or number one risk factor related to mortality and morbidity in the world, is that hypertension does not give a lot of symptoms. So a lot of people that are that having hypertension or high blood pressure do not know they have high blood pressure. Once they know, or they seem to know, or they happen to be diagnosed just because they came to a doctor and he measured the blood pressure, then it's very difficult to treat, because the pills can give you adverse effects. And some pills might work in one person, and some pills might not work in the other person. So it takes a long time for you to be able to find the adequate treatment that is not going to give you as much adverse effects as you will be experiencing. And if you're going to get adverse effects such as coughing constantly or impotence, I think I would rather have high blood pressure. So it's very hard to treat. And once you start finding the treatment, it's very hard to control. So only a limited proportion of people know they have high blood pressure, or only a limited proportion have treatment and they have it under control. There's a lot more than we can do to avoid people from having high blood pressure, because we know that factors such as physical activity, dietary intake, might be related with improvements in blood pressure. With smoking, what we are seeing is an epidemic of smoking that has decreased to a certain extent, but has increased in specific subpopulations, especially in low middle income countries, and especially in women. And we see that the smoking is rising in some of these particular populations. Commonly, what we see with the smoking is that the effects of smoking, the issues regarding morbidity and mortality tend to occur later. So the impact that smoking is going to have on the health of countries such as China, where the prevalence has increased dramatically, or in women, we're going to be seeing it in the coming years. For a long time, we even thought that smoking was good for your health. And a lot of physicians used to prescribe to patients with heart disease to smoke a cigarette every 8 hours to relax a little bit. Also, smoking was considered cool. And as you can see here, there's a picture of this. This is probably in America because it's in the rocks. That's a whiskey. And here is the golden life and the golden reflections, and you're sailing, and the book is there, and who wouldn't want to be there with that cigarette and that whiskey, right? Not only that, even in Formula One until very recently, I remember until 2001, 2002, Spa-Francorchamps, the race in Belgium, was the first one to remove smoking from the adverts in the cars and the teams of Formula One. And in many sports, still, many teams had smoking companies as founders. We've seen also a change in the adverts against smoking, targeting young people, because what we are seeing is that the majority of people that smoke actually start during their teenage life. So it's an issue for teenagers to avoid the uptake of smoking, and it's an issue especially for girls that have been not targeted so far in campaigns. And now what we are seeing is trying to remove what is publicity, putting some scary images that I can assure you do not scare smokers, but that's what we think it works, and trying to make it every time less appealing for people. We even use this kind of images to be able to scare people, but scaring people is not working. If we look in the European Union, what we see is approximately 1 in 3 people all around, the same in Switzerland, are actually smokers. Despite all the knowledge that we have that smoking is not good for our health, 1 in 3 are smoking. We see that 70% of smokers in the European Union start under age 18. And some of the priorities that remain or that are now is improve the advertisement, regulate transborder sales. If you think of this, in France, cigarettes sold outside France represent 20% of the overall tobacco consumption. Who is buying the cigarettes in France? I ask you, Swiss people. I don't know, you tell me. And we need to limit the advertisement for flavors in the cigarettes, or styles of cigarettes that look very thin and beautiful and aesthetic, which have been used by companies to target young women that think they look more beautiful and cooler if they are smoking that cigarette. Another aspect that remains an issue and is very important is obesity. And what we see is that obesity has been increasing dramatically in the last decades in adults, in men and women. It's not an issue only of men. In fact, it's more of an issue in women. And if we look at children, it's exactly the same issue. Dramatic increases in obesity, where almost 1 in 5 children are actually having obesity nowadays. Basically meaning that obesity is not an issue that starts when you become old, but it starts throughout life and requires an emphasis and a prevention that has to be incorporated earlier in life. And it's not surprising to see that obesity has been increasing, because if we look at physical activity, the actual levels of physical activity are decreasing. And it's the same as obesity. Levels of adequate physical activity are a lot lower in women compared to men. And this is the same for children as it is the same for adults. Women are moving less. Somehow we need to move better. And we need to make an emphasis in women actually fulfilling recommendations of physical activity. What about alcohol? There's been a lot of discussion about alcohol. Is alcohol bad for cancer, but good for your heart? How much should I drink? Is 1 glass per day? Is it 2 glasses per day? Doesn't depend on my gender. And basically, we ran this paper, which was an aggregation of multiple studies. And what we found, indeed, for cardiovascular diseases, you can see there is an element of protection here when you drink approximately 1 glass per week. But when you look at total mortality, all the bad things that come with alcohol compensate the benefits that come from the heart. And I think in general terms, if we're going to be looking at individuals and health, instead of just an organ, the heart or the brain, the recommendation should be don't drink alcohol. And if you are drinking, drink a lot less. I know it's hard to follow, but that's what we're finding. So how does cardiovascular disease prevention work at the individual level? We just went through what is the situation and some issues that I think are important that remain, that we, working in nutrition, working in nursing, in physical therapy, we could address. That's what I was pointing out earlier in the first part of the presentation. Now I would like to share with you a little bit what happens at the individual level, what happens with the patient. So basically what it does happen when a patient comes to the doctor clinic, being a GP or a cardiologist or the general physician, when they first see the patient, is to count the risk factors. In Europe, we use these tables, which is basically with colors, and you look at the age of the person, so let's say 55, and does it smoke or not, and what is the blood pressure. So for example, you have a man of age 55 that is a smoker, with high levels of blood pressure and high cholesterol, has a 22% risk of dying in the next 10 years. If you stop smoking, you can halve the risk from 22 to 12. And if you become a woman, well, you lower it by 1/3 more. So, but that is not completely possible. But this is how it works. Basically, the patient comes and the doctor goes through a list of assessment that is going to give you a total cardiovascular risk. So, The guy arrived. What is your age? Are you a woman or a man? You get some points. What is your total cholesterol? Depending on your age and your gender, you get some extra points. What is your HDL cholesterol? What is your systolic blood pressure? Again, depending on men, women, and whether it's treated or not, the smoking status, and then at the end, you add all the points. Yeah, it's very simple, right? It takes time because you have to ask all these questions and measure them, but it's very simple. And you then obtain a total risk. So if you have 13 points, you have a 10-year risk of 12%, basically a probability of dying by 12% in the coming, dying or getting cardiovascular disease in this case, in the coming 10 years. How do you feel about 12%? Is that a lot? Is that little? You don't care? Anybody cares? Is anyone afraid with 12%? You are afraid with 12%? You don't like risk. Are you afraid with 12%? Not at all. It depends also in the concept of risk, and also cardiovascular event tends to occur later in time. So it's something that is difficult to make it tangible for younger populations. But let's say we have a patient, just to have some practical terms. This is a guy, WJC is a patient. Do you know WJC? William Jefferson Clinton. This is his real examination. In the year 2000, he comes to a doctor. He's age 52, he's male, this is his height, BMI is 28. We all know he's overweight. Waist circumference, again, a little bit round. Blood pressure, 150 over 88 is high. And the total cholesterol, for those that don't know, is high, right? So he comes to you. Bill Clinton is in front of you. What are you guys going to do with Bill Clinton, like for prevention? Would you do something? Would you send him home? Would you tell him to divorce Hillary because he's a bad influence? What would you do? Anyone?
More mobility, more sports, and then reduce the blood pressure.
Is that the first thing that you do?
Yeah.
So Bill is sitting in front of you and I say, this is my examination. And you say, move more. And you say, but what is my risk? So the first thing will be to count the risk factors and calculate the risk of Bill, right? So let's say we calculate them and it's 13 points, which is basically what I was talking earlier, the 12% risk. So you tell Bill, you have a 12% risk of getting a cardiovascular event in the coming 10 years. Now what are you going to do? You're going to tell him to move more. Why?
Well, I mean, with each year to increase your risk, presumably,
Uh-huh.
I would say.
So if you move, you get closer to the end, or what else would you guys do? Will anybody do anything else? So let's say you tell Bill Clinton to move more. And in fact, he got that recommendation, and I guess you've seen in the news, or this is a little bit old, but for those that are older, like me, we remember in the news seeing Bill Clinton running, and there were images of him running. So he moved more. What else would you do? Anybody?
Check his smoking status, alcohol consumption.
Okay, so you'll ask that. What else would you do? Stress levels, what else would you do? Anybody else? Would you send him home? Okay. This is Bill Clinton. Have you guys ever been in Iceland? You've been in Iceland. You've been in Reykjavik. You too. So I'm flying to Reykjavik. I'm going to Iceland, and I'm reading in the plane the newspaper. It's The Guardian. They had made an election of what was the best hot dog in the world. And the best hot dog in the world, actually he holds it in his hand, is in Reykjavik. That's what they said. So I was going for a meeting, and I couldn't stop thinking of the best hot dog in the world. That must be amazing. So I remember I went out of the plane, went to the meeting. I was in the meeting, and a lady was sitting next to me, and I said, did you know that there is the best hot dog in the world in Reykjavik? She said, you are kidding me. I said, no, I'm serious. Do you want to go and eat it? She said, well, why not? The meeting wasn't that interesting. So we just went out, and we stopped a taxi. We don't speak Icelandic or whatever. I don't remember what they talked, but I just said, best hot dog in the world. The guy knew where to take us. And he took us to a big parking lot where was a small car with this lady and a queue of 12 or 14 tourists trying to buy this best hot dog in the world. And then when I came there to buy, I ordered 2 because they were so bestest hot dogs. I wanted to eat them and be able to enjoy them. And there was a picture of Bill Clinton behind. After that, I heard I don't know if Bill Clinton is going to look at this stream, but if Bill Clinton is looking, he can confirm that his pictures happen to be in the best kebab in the world, the best burger in the world. So you guys that work in nutrition, you told them to move, but you didn't tell them anything about diet. And in fact, 2 months after this picture, what happened to Bill Clinton? He started on a statin in 2001, and in 2004, 3 years later, he got a bypass surgery. What can you conclude from this? What do you guys think you can conclude from this information? First, lifestyle is important in prevention, and maybe he should have been advised on not eating the best hot dogs in the world and all that stuff, right? And I think I shouldn't be eating the best hot dogs in the world either, and I should be attending the meetings more. What else? That 12% is actually meaningless. Cardiovascular prediction is extremely difficult. Anything regarding prediction about the future, especially if it's about the future, is difficult. Right? I mean, there is no prediction that is not about the future. Right? So, prediction of cardiovascular disease is very poor. And it's even worse in women because the majority of the risk factors and the equations have been developed in populations that were mainly males. And it's even worse in other ethnicities because it was mainly Caucasians or white people, because I don't know how many of us come, or how many of you come from the Caucasus. So basically, the majority of people that are dying from cardiovascular disease are actually from low and middle income countries and happen to be women as well. And none of them have sufficient evidence to actually apply adequate cardiovascular prediction. In a few years later, I think this was 2009, 2010, the American Heart Association decided to introduce a different concept. Since we are very bad at predicting, maybe we should improve a way of maintaining health. And they introduced the concept of cardiovascular health. And they talk about poor, intermediate, and ideal health. And they introduced something that is called the Life Simple 7, which is basically a number of factors that combined contribute to maintain or obtain cardiovascular health. Smoking, body mass index, physical activity, a healthy diet, total cholesterol, blood pressure, and fasted plasma glucose. Okay. I don't know what is your opinion, but first, I don't think they are very simple, right? And second, it's very much again the same perspective of the disease prediction based on the same type of evidence, based on the same type of populations, but phrasing it in a different way, trying to phrase in a positive way. And they try to present things as Life Simple 7, and they put this man, again, with a heart, and things that seem to be relatively easy. And we know those that are working in behavior and prevention that these factors are very difficult to accomplish. In fact, when we measure this type of factors in the general population of the US, we see that among adults, as you can see, there is not a single person, there are persons, of course, there are weird people around that follow a healthy diet. But the majority of people don't. And the same applies for physical activity or for body mass index, as you can see. And if we look at children, the picture is very similar, and the diet is even worse. So cardiovascular health is an interesting concept. It could be incorporated because it resonates better with younger populations, but I think it requires a more mature perspective and an application into populations that are not Caucasian, women, and low and middle income countries. So how do we do this at the population level? If we think that at the individual level is extremely challenging. We cannot predict well, the evidence is not sufficient. We are excellent at treating once you get the heart attack, but who wants to get a heart attack and be treated? Nobody, right? So what about the population level? At the population level, we have a response from the World Health Organization that is called the Global Action Plan, released in 2013. And this is exciting because it's trying to communicate a message to the world about raising priority to non-communicable disorders. This is not a priority in many countries. Women and children are a priority. Basically, the disease of infectious diseases, deaths of the infectious diseases, child mortality, and infant mortality and maternal mortality. Yet, these countries are facing a double burden because they still have high levels of infant and maternal mortality, but they have a huge burden due to blood pressure, cardiovascular events, and diabetes. So the first message from the WHO is we need to raise priority that the infectious diseases are not the only problem in this country. Second, we need to strengthen national capacity because the majority of the countries do not have good strategies or organizations targeting non-communicable disorders. We need to create health-promoting environments. It's very easy to say, go and bike. Try to bike in Bern, and you have a mountain. Or you have a bike line that suddenly disappears. And then you don't even know where you have to go, and you have a guy in the car insulting you because you're doing the wrong thing. So it takes years, and in the Netherlands, 30 or 40 years ago, in the 1980s, there was a national campaign and a complete refurbishing of the infrastructure to allow people to bike. Now in the Netherlands, everybody bikes. And you don't bike, they kind of force you to bike. Which is not that bad, right? But basically, we have to create health-promoting environments. How health-promoting is it that you go to Migros and you have to pay 2 or 3 Swiss francs to buy a kiwi? Is that health-promoting? That's what I pay for a... How much do you pay for a McDonald's burger? Probably it's only $4 or $5, right? So why would you buy the kiwi when you can buy a full meal? How is that health-promoting? So governments have to create health-promoting environments, facilitate the intake of things that are healthy, either physical activity or diet. 4 is a very important point as well. Promote people-centered primary care and universal coverage, because in many low and middle-income countries, there is the latest technology for the richest, but the majority of the poor, and even those in low and middle class, do not have access to. And there is an emphasis on creating every time more specialized clinics and not facilitating the access to primary care. 5, high-quality research, because many of these countries are not running any research programs. They don't have surveillance programs, they don't know the size of the burden, they have very limited efforts, and how can they target their population where they don't understand the distribution of risk factors? That is related to point 6, which is our monitoring. There are 3 key recommendations in the Global Action Plan that I would like to take you through. The first one is population-wide reduction of cardiovascular disease and non-communicable disorders by shifting populations' means of blood pressure, blood cholesterol, and blood glucose by reducing the exposure to lifestyle factors, mainly diet and physical activity. Does it sound to you familiar? Shifting population means, where does it come from? Normally, when we started discovering the risk factors for cardiovascular disease, we started using something like this, a tensiometer. We measure blood pressure, and we say below this is normal, and above this is hyper. This guy, George Pickering, in the 1940s and 50s, this is a cardiologist from the UK, said that this is rubbish. Hypertension doesn't exist. I heard it from the first time in 2005 from Rod Jackson. I was in Foz do Iguaçu, our colleagues from Brazil. So I was watching this, and he got up and said, Rod Jackson is a famous scientist from New Zealand, and he got up and said, hypertension doesn't exist. And I thought, what did he say? The same with the whole audience. I think they wanted to lynch him. But what was George Pickering saying? Basically, he said, if you look at the distribution of cardiovascular risk factors, blood pressure, blood cholesterol, blood glucose, this is normally the distribution. It's a normal distribution. And what we do, if we look into Japan and Finland, for example, this is for cholesterol. You see there is a normal distribution, but one distribution is more towards normality, and another distribution is more towards abnormality. So basically, what we do in cutting down 140 as hypertension doesn't really make sense, does it? So what he said is the sharp distinction between health and disease is a medical artifact for which nature consulted provides no support. That was 1954. He added, this is difficult for doctors to understand because it's a departure from binary thought. Medicine can count up to 2, not beyond. And it makes sense. Why do we count up to 2? We have inherited in our Western medicine, the greatest success of Western medicine has been infectious diseases, right? We learn to diagnose. You have syphilis or not. You have it, you get the treatment. You get the treatment, you are cured. You have tuberculosis or not. You don't have a degree of tuberculosis, right? While cardiovascular disease, COPD, and other non-communicable disorders are complex diseases, multifactorial. They are not one single agent. It's not like, oh, you have this bacteria, therefore you have this disease. There are multiple factors. They take a long time to be able to accumulate and produce the disease. And we think that just by measuring blood pressure, hypertension, high or not, and treat it, that we're going to solve the problem. This is one of the students of George Pickering. This is Jeffrey Rose, and Jeffrey Rose basically introduced the concept of population approach and high-risk approach. So far, what we try to focus a lot is high-risk approach. Above this is hypertension. We treat them basically, we bring the people here. Majority of cardiovascular events, the majority of diseases are actually occurring in this part. So what he suggests is instead of just doing this, which still might be necessary for those that have high risk or symptoms, while this is helpful, it won't solve the problem. We need to shift the population distribution. And that's what the WHO is promoting in the Global Action Plan. Shift the population distribution, not just putting down the curve or those of high risk, but shifting towards normality. By reducing exposure to diet, and bad physical activity, basically physical inactivity. So very important orientation with a global impact that we're moving towards this concept instead of just wanting to operate. Also, they say we need to take into account the total risk approach, cardiovascular clinics, not just clinic for hypertension, clinic for diabetes, clinic for hypercholesterolemia, but total risk approach in which we tackle all these factors together, and not just secondary prevention, in which many countries are really good at, in buying the latest techniques, buying the latest technology, and bringing the most specialized technicians or clinicians, which are reserved for the elite, those that can pay. And a focus on equity. Again, very important to bring this to a primary care level and universal health coverage. They pointed out that there will be 9 targets to achieve the 25-25 target, reducing 25% non-communicable disorders by 2025. And those targets, as you can see here, is, for example, not increase of diabetes and obesity in 0%, which is already very ambitious, improvements in physical activity, etc. And the question is, what happens if we achieve these targets by 2025? Will we actually reach the 25-25 target? Some people model it, and the answer is no. The problem is so bad that even if we do these very tight goals, we still won't accomplish the 25-25. But we'll accomplish something. First, we will prevent more than 37 million deaths, and the majority of these will be from low and middle income countries. And if we want to achieve the 25-25, we need a stronger commitment towards tobacco control and avoiding the influence of tobacco companies in policies, in media distribution, and convincing politicians to be able to gain some profit from allowing people to smoke. In the year 2013, there were new guidelines for cardiovascular disease prevention released by the American Heart Association, which basically target some of these aspects of the increased risk of cardiovascular disease in the majority of the population. And basically what it meant when we apply it to a population in Europe, in Rotterdam, what we found is, here are the new guidelines, here are the older guidelines. Basically, you can see there is a lot more red. And a lot more red means, basically, that almost everyone from age 55 in a normal population, especially men, should be taking statins. Some of my colleagues were participating in that publication of those guidelines. And a lot of people attack them. Why are you telling everyone to take statins? They say, it's not our fault. They are all at risk. So what are we doing? Again, focusing on the treatment and not focusing on the risk factors. What about the future? Are there solutions? What is going to happen? If we look into the future, by the year 2040, if we look in 2016, is ischemic heart disease and stroke are the number 1 and 2? 2040, the same. Lower respiratory infections remains there, but many of the other red things here are going down, as you can see. And you see COPD, chronic kidney disease, Alzheimer's disease, and diabetes, and cancer, lung cancer, liver cancer, coming up. Basically, every time more people dying from non-communicable disorders, every time less people dying from infectious disease, unless something happens, a new pandemic occurs and kills a lot of the population, like happened with the last influenza pandemic. And if you look into the future, what are the key risk factors into the future? Remains high blood pressure, high BMI, fasting plasma glucose, tobacco, alcohol, pollution, something that we don't pay attention to, pollution and high cholesterol. Again, the key killers, the key risk factors for killing people around the world being those related to non-communicable disorders. So will we see an increase in cardiovascular disease and non-communicable disorders? The answer is probably yes, most likely yes, and the majority is going to be happening in low and middle income countries. And I use an example just to show you why. China. If we look at the Chinese populations, 1 in 3 Chinese will be over age 50 in 2025. That means that the population in China, the distribution, the demographic distribution is changing. There's every time more old elderly people. We ran a study in the year 2008 looking at the normal population of China, looking at populations in the north and south of China, Beijing and Shanghai. And we found that, look at this, 67%, let's say on average 50%, had overweight or obesity. Metabolic syndrome, 50%. Abdominal obesity, 50%. Diabetes mellitus, almost 20%, which is far larger than populations as in Switzerland, but it's gonna get worse because this is a time bomb. The impact of overweight, obesity, and metabolic syndrome, first, is a change. It's occurring recently within the changes in lifestyle that have occurred in the Chinese population. Increased affordability. You can eat more. You can buy a car. You don't need to ride a bike. And you can afford a good life. Which means increases in diabetes, cardiovascular disease, etc. And this is only going to get worse. What else? We already have medications that seem to work. And some of those medications are not that expensive. Nevertheless, they are not being given sufficiently to people or not monitored sufficiently. That means that if we look at to the medication adherence of any cardiovascular drug, we found that almost half of people prescribed with the drugs actually take them. And you wonder why. One important issue is that, first, these drugs give adverse effects. Second, this is mainly prescribed for people over age 50 and 55, which normally have other conditions. And they end up taking 3, 4, 5, 6, 7 pills. They don't remember to take them all, or they get confused, or they just don't take anything, or they take them the wrong way. How to solve it? In 2003, some people suggested the polypill concept. And basically, it was a strategy to prevent cardiovascular disease by more than 80%. I was very impressed when I read this paper. It was published in the British Medical Journal. The editor wrote that it was the most important BMJ in the last 50 years. Invited everyone to buy a copy and keep it for posterity. I was doing a PhD in Erasmus. I couldn't afford it. I didn't buy a copy. If anyone has a copy, I'm still looking for it. What is the polypill? Basically, what they said is the joke that everybody was doing. If you have 6 or 7 pills and they have to take them all, just put them together in a single pill. They don't have to remember which one. They just take one. So it facilitates medication adherence, right? So they created this polypill, which is basically 3 types of antihypertensive, statin, folic acid, and aspirin. Brought together will reduce stroke by 80% and coronary heart disease by 88%. What is the advice that they do? you have to stop measuring blood pressure, blood glucose, cholesterol. Is a total waste of time and money. Why? Because 96% of cardiovascular events occur in 55 pluses. So very simple. Don't measure them. Just everyone, when they turn 55, give them the poly pill. What else? It's not a joke of the poly pill. Everybody thinks that maybe it's a joke. The idea is patented, is being developed. There are poly pills already developed by different pharmaceutical companies. I don't know when they're going to be coming in the market. You can imagine the type of obstacles of people not wanting to have a cheap poly pill that could reduce cardiovascular disease by the same or more than an expensive pill, right? But this could be a solution for low and middle income countries where there is not a capacity to deal with cardiovascular disease pandemic in the short term. In the short term, in the long term, maybe we can improve prevention, but in the short term, there are people dying, and we have to do something about it. Nevertheless, if we think of the adverse effects, I don't know how many of you know people over age 55. You know some? Yeah, they are kind of normal people, right? Kind of healthy, normal. They go. Some of them work, right? So imagine if you take all these normal people, and we know the population are aging, so you have millions and millions and millions of people taking pills that they were normal, and suddenly they start having adverse effects. Doesn't make sense. And even if it's very cheap, we're talking about millions and millions of investment. Is that the right solution? So I remember one day I came to visit my father-in-law. I hope he's not watching, but I came to visit my father-in-law. He had a stroke before, and I found him smoking a cigarette. And I said to him, "What are you doing?" And he said, "It's been all over the press. This magic pill is going to cut cardiovascular disease by 80%. I don't care much about him, but I thought maybe what we can do is find a more natural, safer, and probably tastier solution that the poly pill that I call the poly meal. And basically, it was just like the poly pill, but I selected things that I liked, like wine, fish, dark chocolate, fruits and vegetables, garlic and almonds, and then looked for the evidence from randomized controlled trials and meta-analysis, brought them together, and calculated that together could reduce by 76% cardiovascular disease. We used data from Framingham and multi-state life table to calculate that the poly meal given to a man from age 50 could save 6 years of life expectancy, 9 years free of cardiovascular disease life expectancy, which is comparable to 11 years that you could obtain from the poly pill. What are the recommendations? First things, there could be adverse effects from the poly meal. So if you have a date, do not take the poly meal because it can give you flatulence and halitosis. Unless your partner is actually eating the poly meal, and then you know how it works with garlic in France. Nobody smells the garlic anymore. I don't recommend any particular brands, but if you improve and you invest a little bit more in your wine and your chocolate, you can also improve your quality of life. And you don't have to eat them all at the same time. It's basically selecting the right products at the time that you go to the supermarket. How about women? That's another aspect for the future. I think we need to improve prediction and treatment in women. I've been saying it all the time. There are more women dying from cardiovascular disease than men. And we see that the lifetime risk for men and women is the same. Just women present differently. They have more heart failure and stroke than coronary heart disease. And this is also the case because women normally don't get the Hollywood heart attack. They normally get a pain somewhere else. And women are very good with pain, men not. So if we get a little pain, we go, heart attack? No, it's just an ear infection, okay. But women, they get a heart attack and they just keep on going, I don't know. So we need to improve the prediction in women. We try to do that. Basically, we use an imaging to look at the calcium in the coronaries to see whether that could improve, and improves a little bit, but not sufficiently. There is a lot more that we have to do. How about new biomarkers? We heard a lot of artificial intelligence. Now everything is artificial intelligence, and it seems that it's going to solve absolutely everything. Could it solve it? What about omics and genes, etc.? And I leave you with this paper. It was published recently, 2018, Journal of American College of Cardiology, where they look at the impact of genes for the prediction of cardiovascular disease and compare it to all the other risk factors, as you can see here on the graphs. And basically, with the genes, right at the beginning, when you can test for your genetic composition, you already have a very good picture of who is at higher risk or not of developing cardiovascular disease. Is that good or bad? Would you have your children measure? Would you measure it yourself? There is a lot of ethical considerations. But I think one important aspect is that the majority of risk factors, blood pressure, cholesterol, glucose, smoking, bad diets, you saw it in the slides, obesity, physical inactivity, start much earlier in life than when people get a heart attack at age 55. And what we are proposing, or what we are doing so far, is waiting for them to get the heart attack to put a stent on them, or to see them in the clinic and tell them to move, like with Bill Clinton. But we are not doing anything with the rest of the population. Shouldn't we actually, to prevent cardiovascular disease, have a life course approach? And if so, how? And I leave you the question open for you, and that's my final slide. Thank you, Mauricio.
Thank you, Oscar. Thank you very much for your excellent presentation. We have time for questions, and I mean, you have big questions for the audience.
Yeah, today there are no questions from the audience, but for the audience.
For the audience, yeah. Yeah, so of course we have, if anybody here in the room has a question, please. I'll switch the microphone on. It should be green. Green light, yeah.
Thanks for your presentation. Quite enjoyed it. I'm quite intrigued by the fact that you're saying, well, this is all kind of bullshit to measure blood pressure all the time, you know, and give them statins and stuff like that. Well, I can tell you that DeBakey will probably not be very happy about those recommendations, because he's actually advertising for the statins in the US television. But anyhow, I'm a bit confused, because just recently they were publishing new blood pressure references. Actually, they want to lower it even more. So what are you saying about this? Are they just not hearing you? What's going on?
Mm-hmm. So thank you for the question. I never said the word whatever you said, but you've been recorded. So and I didn't advise people to stop screening. That is a paper that was published. The polypill authors. I didn't co-author the polypill. Is that what they suggest as a way to improve cardiovascular disease treatment? I think what we are seeing is that we are all at risk of cardiovascular disease. Our levels of blood pressure, glucose, and cholesterol are all at very high risk. What I'm advocating is for a population shift in the distribution of these risk factors by improving the access to health-related behaviors. I want to bike, I want to eat properly. Please, let's build a society, or let's all get together to facilitate that those that want, that those that require it, can actually achieve it. And there is as much as possible as you can force, but there is just as much as possible as you can facilitate. And I don't think we are facilitating it. That will be my personal perspective. Yeah.
Thank you. Any other questions? The polymeal, very inspiring concept. I don't know, maybe the nutritionist between us, what do you think about that?
I wouldn't call it inspiring, maybe smelling, but I'm not sure if inspiring.
Well, maybe I can add a little bit on what you finished with the former question. I think it's not about the polymeal. I think that there are maybe 5 things you could properly do, which is quite concrete and easily. It's about all the other things we should stop doing. And changing that in this environment, I would fully agree with you, is like almost impossible. We don't want to move more. We want to watch more television. We don't want to eat healthier. And the environment is stimulating that. And I think the discussion should be more about that than on the medical treatments. So not a question, but more a comment.
And I agree with you. I think many times it's not whether we want, it's whether we can afford it and whether it's within our reach. Many times it's difficult to get access to it. You go to the canteen of where you work or the restaurants around you, is what they serve. Here, it's very hard to get vegetables. Go to one of those menus in all those restaurants. They give you always a salad at the beginning, And then there is a main course that doesn't come with any vegetables. And if you order vegetarian, they just provide you the burger without the meat. That's what they do. So it's very difficult for people that want to eat vegetables to actually get access to properly cooked, well-made, tasty, good-looking, and affordable vegetables. That's a problem. And then what people can afford is, what is eating in Switzerland? Can you try to eat outside? It's very expensive. What can people afford if they don't have a high salary? Where do they go? They go to McDonald's. That's the only thing you can afford. If I have a big family visiting here, what do I take them? I take them to McDonald's because otherwise I have to pay like 1,000 Swiss francs, right? Or what is what you can afford? A fondue that is just full of cheese and bread. So it's not very easy to follow a healthy diet. For a nutritionist or for a dietitian, it seems very easy. But one thing is to advocate and another thing is to follow and to practice. It's very difficult. The same with physical activity. How can you tell people here to take a bike? It's not that easy, right? The buses come in front of you, everybody insults you. It's not the same as in the Netherlands. You're from the Netherlands. You know how easy it is to bike there. Even I can bike there, right?
Yeah, another question here. Oh, wait, yeah, it's working.
Thank you for your excellent talk. I understood this was mainly about the focus was on primary prevention with the general recommendations. My question is about, we're now in the time frame of precision medicine, of tailored solutions, individual solutions. Do you have any thoughts about this?
Yes, I think we can utilize better approaches to understand the mechanisms and to distill how specific mechanisms or factors are acting in specific subgroups of the population. I think the dream of having something individualized is maybe around the corner, but not yet there. But it's something that we can make more precise by specific subgroups of the population, maybe within a specific gender, ethnic, and age subgroups of the population, to name a few of the characteristics. I think the problem that we have so far is the majority of the evidence and science has been conducted in very homogeneous types of population. Middle age, 50-plussers, white people, and normally men. And we need to obtain further evidence from the other populations, or maybe just utilize the data that is already collected. Maybe artificial intelligence, maybe machine learning and big data might provide a shortcut to be able to understand how these specific populations are experiencing the different risk factors and the risk towards cardiovascular disease or non-communicable disorders. So maybe that will be an avenue to improve more specific or precise interventions that might be more easier perhaps to adhere to. Might be more successful. But we don't know yet. I think that could be the case.
Are there more questions? Any questions? Maybe a question, are there good examples of Western countries who have succeeded in any of these approaches except in terms of prevention of cardiovascular disease? Do you know any country who made any progress in terms of?
There are many countries who had a success. One of the most famous is the project of North Karelia in Finland, where the entire community was modified in terms of risk factors. And we saw Finland was one of the 30, 40 years ago, had one of the highest levels of mortality due to cardiovascular disease. And now it's very comparable to countries like Switzerland, or even lower. I have to check exactly. Mm-hmm. But there are concrete examples in which the distribution of the population has been shifted of the risk factors that I mentioned.
Also in the risk population or on average?
In total, which incorporates the risk population.
Yeah. Okay. All right. If we don't have any further questions, I would like to thank everybody for being with us, audience here and abroad, in Brazil, in Germany, in Austria, and especially our speaker. Thank you very much, Oscar, for being here today. And again, I would like to invite you, everybody, for the 14th of May for our next guest lecture. Thank you. Good evening. Goodbye. Have a schönen Abend miteinander. Ade.
Thank you.